Coffee with Coker is a healthcare business podcast from the Coker Group that focuses on solutions to help healthcare organizations effectively navigate the changing healthcare industry landscape. Welcome, everyone, to the Coffee with Coker podcast. My name is Mark Reibold, and I'm the host of Coffee with Coker. If you are first time listening, we thank you for tuning in. Just as a little bit of quick background, Coffee with Coker is a podcast that covers everything related to the business, operations, and financial aspects of healthcare services. And it's published by the Coker Group. We're a healthcare consulting firm, and we work with hospitals and health systems and physician groups on a wide range of operational, financial, and technology matters. Today's episode is one that I actually did not host. One of my colleagues, Jeffery Daigrepont, who runs Coker's technology consulting group, he hosted along with a guest. This is his first time joining us as a guest, Dr. Neil Baum. And I'll tell you a little bit about him in just a second. But what Dr. Baum and Jeffery talked about on today's episode was a number of things related to healthcare technology, specifically looking at artificial intelligence and some of the things that have emerged recently or in the last couple of years as it relates to AI being utilized more and more within healthcare services, healthcare delivery, and healthcare information systems. And so that's what Jeffery and Dr. Baum talked about. Just briefly, Dr. Baum is a clinical professor of urology at Tulane Medical School in New Orleans, Louisiana. He is a retired urologic surgeon, actually, and he serves as an advisor and faculty member at a number of institutions in addition to Tulane. And he's really a pioneer in the world of healthcare technology. He's been around for many years in the industry, but for much of his career, he has spent a lot of time and energy related to the development of different technologies, information systems, et cetera. And so that's really where Jeffery and Dr. Baum have connected, and they wanted to talk about AI here. Healthcare providers really are spending less and less time focusing on the patient and more time with their heads in a tablet or computer or laptop or something like that. And I think this is something that we're starting to see change with the rise of new solutions, whether it's AI, whether it's telemedicine or other information systems. And we certainly saw the rapid growth of things like telemedicine at the onset and through the duration of the COVID-19 pandemic. And so we're still seeing things come out of that that really is driving the development of innovation and new technology solutions within healthcare delivery. And that's really what Jeffery and Dr. Baum have talked about here. And I think it's a very interesting discussion, but it's something that is becoming very, very relevant for all healthcare providers, clinicians, and provider organizations out there. This is not something that's going away. It's definitely going to continue to be very prevalent. And that's why I think this conversation is very timely and meaningful and will continue to be so. And we'll continue to talk about these things and monitor these things as they continue to develop. So again, we thank you for listening. We hope you enjoy this conversation between Jeffery Daigrepont and Dr. Neil Baum.
All right. Thank you, Mark, for that introduction. As Mark indicated, we are honored and privileged to have Dr. Neil Baum as our guest today on this podcast to discuss artificial intelligence. And Doctor, I was thinking in preparing for this, I was trying to go in the Wayback Machine to remember when you and I first met. I think I'm correct in saying this, very new in my career, and I was asked to speak at the AUA conference, the American Urology Association. And as a new speaker, one of the things I always did to help calm my nerves is I would go into the room that I was going to be speaking at. And I did that. And it just so happened you were presenting, and I caught the tail end. And I remember this amazing speaker that was doing magic and had everybody just really at the edge of their seat, and they were enjoying the the talk, and the whole purpose of me going in there was to calm my nerves. And I was thinking to myself, I have to follow this guy, and I'm the next presenter. I don't know any magic. At best, I know one really lame, icebreaker joke that's probably going to bomb now. And ever since then, I just been such a fan. I've admired your work. I always read everything you write. Never miss an opportunity to hear you speak. And the thing that I think I've admired the most about you is you really speak from the heart, and you speak from with such passion. And you can certainly tell you've been at the bedside with your patients in the exam room. So you're very authentic. You clearly speak from someone who's walked the walk and can certainly talk the talk. So always an absolute honor to have the opportunity to host you here and to get some insights from you on this topic. So welcome, and if you don't mind, maybe introduce yourself a little bit, and then we'll jump right in.
Well, I want to begin by thanking you. That segue and that introduction. I would say normally I would like my wife to hear what a terrific speaker and person I am, and it happens to be that she's in the room here, so she did get to hear it. I remember that very well when we first met, and you came up to me afterwards and complimented me, and we started our dialogue together and working together. And I remember on multiple occasions, I had questions about my electronic medical records and how helpful you were, and what a nice relationship I've had with you and Max Reibold at Coker, and what a terrific organization, and how I have been so welcomed there, and how much I have enjoyed working with you. I think we have written 4 or 5 articles that have been published together. One of the recent ones is on artificial intelligence. I have received very nice compliments on the article, and I think it is a pertinent topic today. As we go forward, it is going to become part and parcel of every physician's practice. Just a few seconds about myself. I was a practicing urologist. I retired 3 years ago. And I'll never forget that I was approached by, it was called AMA News, and they saw some of the things I was doing in my office. They interviewed me, and they asked me if I would be willing to write an article once a month for AMA News. This was about 35 years ago. And I didn't have a lot of writing skills at that time, but I agreed to do it. And after 3 years and 36 months, each one of those articles became a chapter in a book. And I wrote a book called Marketing Your Clinical Practice Ethically, Effectively, and Economically. And that book really was a game changer for me, because it introduced me to hundreds or even thousands of physicians. It sold over 200,000 copies. It's in its 4th edition, and it opened up a whole vista to me of people to interact with and get other ideas, and an opportunity to get on the public stage for discussing things that I were doing in my office. And it was just sort of serendipity that I was interviewed and then invited to contribute. And then it has continued. So even in retirement, I'm still doing articles, working with you and Coker, and creating videos. So it's been a wonderful opportunity to continue having a interaction with vendors, with colleagues, and with pharmaceutical companies. And it's been a wonderful career. And I'm just delighted to be able to continue and to have this discussion with you here today.
Yeah, no, appreciate that. In fact, I didn't mention this, but that book actually inspired me to take a lesson from that, and did some of my own publishing, and really learned a lot from you. Like I said, early in my career, was one of the, I don't know, by luck or accident, whatever you want to call it, but I was very fortunate to have run into you at that pivotal time, because it really did influence a lot of the things I've done later. And of course, as you mentioned, actually good segue, I always found you even before I met you, as an early pioneer of sort of pushing the envelope and doing things at the time that a lot of physicians were not comfortable doing, and specifically introducing technology at the point of care, even at a time when there was a pretty significant high failure rate. A lot of doctors were very dissatisfied with EHRs, and you've experienced a lot of those same challenges, but yet seem to have found a good bit of success. One of my observations about you, and be interested to hear your thoughts on this, is that when you look at technology, it always occurred to me that you put yourself in the shoes of the patients and the perspective of the patient. And I think when we start talking about the subject of artificial intelligence, one of the things that comes to mind is that, as a caregiver, someone that is entrusted. I mean, I always kind of jokingly say, doctors are the very few people that we will literally get undressed in front of. So we really trust doctors at a whole another level that's even hard to describe. And so when you start thinking of artificial intelligence, how do you feel about that very sacred, patient doctor relationship? Is it helpful? Does this support? Does it interfere? What are some of the concerns? I mean, certainly it's new technology, and people naturally can be intimidated. But just in a general sense, what's your, as a caregiver or somebody who had been before you retired, how do you feel like this impacts the physician patient relationship?
It's so interesting that you preface this about you start a interaction with the patient, and the patient will get undressed, male and female, in front of a physician. I never took that for granted. Just when you have two initials after your name, M period, D period, that allows you to start a dialogue with the patient, and you can ask about things about their intimacy, about their menstrual habits, about their bowel habits, their sexual activity, something that they wouldn't share with anyone else. And within just a minute or two after they go into the room with that person with those initials after his name, that profession has the respect of the population, that they can understand that they're safe in there, and that what happens in there is almost like confession, that they can be able to communicate with another person who is a veritable stranger, and they would get one of the two of us gets undressed, that's always the patient, and that you're able to touch them and probe them and examine them, that they wouldn't let anyone else do that. And I often felt that was a very special trust that patients had with their physician, and that it was something that we should never, ever take for granted, when we are with our patients. And that's one of the things about the electronic medical record that I think has been a detractor. And that is, if you watch a physician at work today, he or she is looking at the computer and not the patient. And now we've added telemedicine to that, where particularly millennials, are comfortable talking to a patient virtually without having the doctor touch the patient. And I think that has been a detractor. And as a result, we are seeing older physicians who are resisting the electronic medical record and using that as one of the excuses for early retirement. And I think we have given up a lot when we have used the computer as a replacement for our empathy, for our understanding. And now we are using the COVID has allowed us to have virtual communication with our patients, and where there are at least 50% or 60% of conditions that are being treated today when you come back to the doctor, and you have to spend 3 to 4 hours till you leave where you are, your home, your office, you travel to visit the doctor, you park the car, you get into the office, you wait in the reception area, you're taken to the exam room, you wait there, and you have a 15-minute visit with the doctor, and then you have 15, 20 minutes to check out, then you have to go to the pharmacy. We're talking 3+ hours, yet they can be seen in 15 minutes, virtually, without the doctor touching them. I think we lose a lot when we have left that paradigm of taking the history, touching, examining the patient, and providing empathy and understanding. Our article that you and I wrote together, and I guess we'll share it with anybody that wants. The article we wrote was artificial intelligence will not replace us. And the artificial intelligence is not able to hold the hand of a patient, to provide understanding and compassion, towards the patient. And yes, artificial intelligence, can read a mammogram better than a radiologist. Artificial intelligence can screen for skin cancers better than a dermatologist. A dermatologist may only see 13,000 skin cancers in the lifetime of a dermatologist, whereas artificial intelligence has reviewed several million pictures of the skin and accurately can diagnose skin cancer as good as or better than a dermatologist. The only exception where it isn't necessary to touch the patient is the pathologist. The artificial intelligence is being used to read pathology slides, but it isn't necessary for the pathologist that never touches the patient.
Probably radiology too, to a certain extent.
Yeah, well, but the person goes to the
imaging center,
radiology center, is imaged. Will often chat with the physician, and the physician will either talk to the patient, talk to the referring doctor, or the one that would do the biopsy. There is more hands-on with a radiologist than with a pathologist.
Yeah, I'm referring more to the reading of the X-ray. I still think you'll have to have a radiologist involved from the ordering, and then of course the diagnostic imaging center where the patient will literally get under a machine or in a machine. But we are seeing AI, especially doing overreads. I know, like in ophthalmology, the retina scans, that's almost 100% AI now. And surprisingly, the doctors were not against it. They actually found that it gave them greater capacity and gave them more meaningful time with their patients when they can look to automate. And something real quick that I probably should have did at the beginning, just to sort of level set what we do see in the healthcare market. There's really sort of two types of AI. There's when people say AI, they're really referring to the umbrella term that covers all machine learning. But there's two types of machine learning. There's the algorithm type, which is sort of if and do what, and that's based on stats and statistics. So it knows based on large quantities of data that this is the particular outcome that we're looking for. So a great, easy example of that is, let's say a bot is doing a patient intake. Well, just the first question, male or female, would eliminate thousands of questions if the patient said, I'm a male, because anything applicable to female doesn't now apply. Same thing with the next question, do you smoke? Yes or no? Well, if you smoke, now we have a whole nother set of questions. How often, how long, how much, those kind of things. So the AI is sort of looking for the logic that goes with driving to an outcome. Deep learning, on the other hand, is a little bit more science fiction. This is where the machine is capable of looping back those outcomes constantly and determining, can they dial in the outcome more precisely. Each and every time it re-examines itself, it re-examines the outcome, and over time it builds its own network of logic and algorithms to further advance its capabilities to make good decisions. I would say the vast majority of AI that we see in healthcare today will fall into the machine learning category, and even those machines are capped off, meaning they don't learn beyond their intended purpose. So, I don't think we'll ever see a scenario, oftentimes jokingly say, maybe AI can cure cancer just by killing off all the humans. I mean, it's one way to do it, right? So you sort of have to, people get a little bit nervous when you start thinking of AI. Does it replace, the human? And the one thing that I think if we can ever, I think we would cross the line if AI ever developed a conscience. That's where, scientists all around the world, no one can really explain where a conscience comes from, right? It's that deep compassion piece that Dr. Baum was just describing. And, you were just describing, Doctor, how these machines can read and interpret skin cancer. Well, can you imagine if the AI took it to the next level and a chatbot calls the patient to deliver that news, right? I mean, that's an example where I think, it's technologically possible, but is it ethically correct to do it that way? And I remember listening to one of your talks about social media, and the question was, how do you address a person that is upset with the doctor? And I was surprised. In fact, a lot of doctors are surprised to hear your answer. You'll pick up the phone and confront the person. I mean, you call them or say, hey, call me directly and let's have a conversation. So I know your ability to connect at that level is important, and maybe share some thoughts about where you think AI would cross the line as it relates to communicating with your patients.
Well, that's a good scenario for us to take off on, and that is, if a patient comes with a issue, a problem, and a test or imaging is done, and then the AI is the one that contacts the patient, that would be completely unacceptable. Patients don't want to be treated by an algorithm. They don't want that. Patients want a caring physician, to do the communication. And I don't see in the near future that AI is going to start. They're going to make suggestions. They're going to give a differential diagnosis. They're going to categorize which ones are more than likely than not to be the case. They will tell what additional studies to be done, but they're never going to hold the hand of the patient and provide that empathy. And the patients still want to be treated by a human. Let me give you an example. AI has a very small role in the telephone tree when you call it an office. You can tell the tree, I would like to speak to the nurse, I'd like to speak to the billing person, I'd like to speak to the doctor. But patients don't want that. Patients aren't interested in the phone tree. They want the phone to be answered in 3 rings, and whenever possible, they want to be directed to a human as quickly as possible. And the minute the doctor starts allocating all of these activities to a computer, then the doctor will become unnecessary. But that's not what patients want. And I think successful practices and successful doctors do two things. They find out what the patients want and give him or her more of it. They find out what the patient doesn't want and avoids it. The patient doesn't want to be allocated to a phone tree or to an algorithm. And the moment that we recognize that, and the moment that the doctor now becomes part nurse, medical assistant, social worker, psychiatrist, that's the kind of training that has to come forth in the near future. You know, medical training is memorizing thousands and thousands of pieces of data and then have to regurgitate it back. But that isn't what the patients are looking for. Doctors are going to need more training in communication. They're going to need more training in managing diversity, more skills in managing the disgruntled patient. You know, so many times a doctor, you know, who's dealing with a difficult patient, you know, just says, let them find another doctor. Well, that's not going to work, you know, going forward. They're finding another doctor is not the answer. Only when a patient is abusive or does things in a racial fashion, you know, or is dishonest or is causing havoc, you know, with the staff, only then is it important to discharge the patient. I've been in practice 40 years. I can count on two hands the number of times that I've had to discharge, less than the number on two hands. It's more than one hand, but not two hands. The number of times and I have seen over 35,000 patients. That's not a bad statistic.
Well, it sounds like what you're describing is really a concept where the machines would complement the caregivers and enhance the experience of the patient. I mean, I think one of the challenges that we face as a nation, and if there was ever something that put the spotlight on it, COVID certainly did. We clearly have an access challenge. We clearly have capacity challenges. We clearly have caregivers that are just, you know, you hear burnout a lot, you hear fatigue, you hear just being at their wits' end, trying to meet the needs of our communities. And I think where AI could support our health system is looking for ways to automate some of those repetitive tasks. Like, for example, one thing that I'm very excited about, and this does make people feel a little bit uncomfortable, specifically doctors, but one of the things that technology's really gotten good at is listening to us and then anticipating. And so, you know, that we have these listening devices in our homes now. And just by saying a few words, my Alexa can actually believe it or not, knows when my AC filter needs to be replaced and automatically orders my filter. And it just shows up. I used to like break my air conditioner because I travel. I was the worst at changing the filter. Now it's signaling me to do something about that. And there is some development now occurring where they're putting these listening devices in the exam room and actually linking it back to the patient's general data as a whole. So, for example, you're getting ready to take a patient into surgery. I assume a common question you would ask is, are you taking blood thinners, right? They could bleed out. Well, you know, the patient might not consider fish oil a type of blood thinner, but Amazon knows that fish oil was ordered by that patient and could prompt the caregiver to say, wait a minute, I just heard you ask that question. We, the big collector of data, LexisNexis, these other companies, you know, they track like 5,000 to 6,000 data elements on each one of us. So if we could integrate information that could save a patient's life at the point of care, intervene, I could see some real, you know, benefits in that. I think the one caveat for me, and I'm putting my consumer hat on for a second, I think as long as the consent is there, right? I mean, I think a patient should know that hey, we're using a device that's going to help us be better caregivers, deliver safer care, have better outcomes, and would love to have your participation and your consent to do this. I think it's a good experience that would help both of us. How do you feel about the concept of a listening device in your exam room? I mean, does that make you feel a little uncomfortable?
Not at all. I have nothing to hide if the patient gives their permission. Many a times I will encourage a patient to record our discussion. A man comes in with a positive biopsy, and we have to have a 20 to 30 minute discussion. There is no way that he or she is going to remember everything that we discussed. And I encourage them to turn on their cell phone and to record the discussion. I have nothing to hide. I want to back up to something else about what AI can do that I've written about it, but you and I haven't discussed it, and that is compliance. The majority of patients who are given a prescription will stop take the medicine inappropriately and not refill their medication. Now, I'm talking 60 to 70% of that applies to 60 to 70% of patients. And that's particularly important when they have treatment for a condition that doesn't have any symptoms until it's too late, like hypertension. There are no symptoms for hypertension, and yet significant numbers, and I'm telling you it's 60 or 70%. Now, there are listening devices that can be put in the patient's home that will talk to the patient, remind the patient to take the medication. And if the patient doesn't take the medication, the listening device will call back. Those listening devices can be placed in the bedroom, the bathroom, the kitchen, any place that the patient agrees. And if the patient doesn't take the medication, with the patient's permission, the caregiver will be notified and the physician will be notified. This, as a result, improves compliance, it improves outcomes, it improves, decreases readmission to the hospital, and the patients are better cared for when we relegate this to the artificial intelligence to help us make patients better patients. Because the doctor can't, the doctor sees the patient for 15 minutes and then the patient returns in a given amount of time. The continuum of care takes place between those two visits. Right. And the doctor can't be there at all times, to advise and to treat the patient. Artificial intelligence can be a huge plus, right, with these listening devices. By the way, when you mentioned Alexa, my machine lit up right behind me. And he's going, "Who's Jeffery Daigrepont?"
All right. Always listening. Some people actually have projected that the hospital bed of the future may very well be in your home. If you look at our hospital beds, a lot of those beds are occupied by people that are not in serious conditions, but do need monitoring nonetheless. So the technology now, I know like in behavioral health, they are now dialing into your Apple Watch, and they can tell if somebody who's maybe a little bit suicidal or has issues hasn't moved in like 3 days. They haven't left their house, and a social worker can go out there and check on them. They now have technology that can actually tell by the tone of your voice if you are truly having a stressful situation or if you're in pain. I know pain management struggles a lot with drug seekers and things akin to that. And they now have the technology that can actually tell if it's genuine pain versus someone just attempting to, con a physician into writing a prescription and maybe, grandstanding a little bit about their pain. So that's a pretty interesting development. But I do think these tracking tools, monitoring tools, at-home devices that can integrate with the caregiver, because to your point, you get your 15 to 30 minutes that's it. But care continues to go 24/7. And it almost always is sometime in the middle of the night or at an inconvenient time for both the doctor and the patient when you might actually need some intervention. So I do think that we're going to see more development on the monitoring, tracking in a virtual setting.
I want to give you an anecdotal story about the watches. I have an Apple Watch, and I was on one of those exercise balls, the big round ball, and I was doing sit-ups or crunches. And the watch goes off and it says, "Are you okay? You appear to have fallen. Do you need assistance?" And I said, my gosh, it is really looking out after me, and it wanted the reassurance, although I was on the ground, they didn't know I was on an exercise ball. But what isn't that reassuring? Can you imagine if you're an older person who has a situation of frailty and falls down, and you're wearing one of these watches and it notifies EMT or calls the caregiver or the doctor and gets you assistance immediately? I think these are all the good things that AI is going to do. And we have to focus on that. Let's just talk a little bit about physician acceptance. You and I are, you more than me, are extraordinarily sensitive that physicians don't take new ideas and new technology and accept it very easily. And, there's that bell-shaped curve that you and I are very familiar with. It has, the innovators, which is a very small number, and then there's the early adapters, and then there are the early majority, followed by the late majority. They're the ones that are looking for the proof, the data, the articles, and then there's the laggards. They catch on when already the new disruptive technology has been implemented. That was, eye opener to us with EMR. Very few people embraced it, in the beginning. There was a tremendous amount of resistance, especially with middle-aged and older doctors who weren't comfortable with the computer or with typing. And yet, today it is part and parcel of nearly every medical practice, and it is not perfect by any means, but it is a far better way to analyze, accept, and record data than it was in the past. And I see artificial intelligence having that same uphill road or ladder to climb in order to reach its, there are already early adapters, who are involved in it. And I think the more that physicians become involved and not computer programmers, who are telling us what we need to do. And I think that's when electronic medical records reach the point of acceptance, when doctors got involved, because we knew what patients needed and want, and we knew the workflow of physicians. And so I would like to throw this back to you. Do you see us duplicating the rise and acceptance of artificial intelligence similar to what we experienced with the electronic medical record? You understand my question?
I do. And in fact, I think the electronic record, medical records is the precursor. So in order to be successful at AI, you have to start off with data, and good, bad, or indifferent, the electronic health record system is where we collect and store that information. Some systems better than others. Some doctors are a little bit more discreet in terms of how they store their data. But we always tell clients that are interested in investigating whether or not AI is right for them to not even attempt to go down this path unless you have a very solid grasp on your data management, because everything that AI depends on is going to be predicated on how well you can manage your data. That's the key, and that's the building block to be successful. And then we recommend that you start with maybe simple things that are repetitive tasks that you can automate. So, like your call center, for example, there's a lot of even internal, if you're a big health system, self-serving IT support that you don't have to call and sit on a hold forever. You can, get your computer supported by a machine now. There's little things that you can do to get started. But I think the entire premise of AI has to be built on a good, solid foundation of standardized, reliable data. Otherwise, it's just going to be garbage. It has to have a good foundation.
And let's both of us weigh in. How do you see implementing this, and how do you see getting doctors on board? My thought is that they've got to take baby steps before they run. They've got to get comfortable with some aspect of it that fits in their work style or their communication, with patients, and to demonstrate to them that we can show them that it enhances patient care, that they become better doctors, not just memorizing lots of data and looking up articles. AI is going to do all that for you. AI is going to summarize and look at thousands of journals, of which a doctor, the average doctor at most can look at 2 to 4 journals on a regular basis. This is going to look at thousands of articles and journals and be able to summarize that and attach that to the patient. We will become better doctors when we embrace AI. How are we going to get that across?
Yeah, the most common answer I hear, and I always cringe when I hear people answer it this way, but I'm going to say it because I find it a little bit insulting to doctors. But usually people will say, you got to show the doctor the financial upside before they embrace anything. And that's probably true to an extent. But I'll tell you what doctors enjoy even more. They really want to be better doctors. They want to deliver high quality service. And you know what they want more than even that? Sometimes they want back their time. They want to have good quality time. They want to have a meaningful interaction with their patients and not being distracted with all this bureaucracy that we currently put on physicians today, whether it's making sure you have permission to do something that's needed and necessary and consistent with medical standards, but you have to get approval for that kind. All those burdens that cause physicians to lose interest in their profession. I mean, most doctors went into this because they wanted to be caregivers and they have the mind. In fact, everybody will always actually be critical in saying doctors are not good business people. That's because they're not trained. They never had that training. And so I think doctors, while there is financial upside to this, if you can demonstrate to them where they can have better outcomes, more time, get back their time, and they can have meaning and purpose behind it, I think they will embrace it. And that's true of almost anything. I know that one of the things that really got you national recognition, and you'll know exactly where I'm going with this story. You came up with this brilliant, I think it's the best marketing I've ever seen. You basically said, look, if I'm late, I'm not going to charge you for my visit. Now, you and I both knew you were going to be late on occasion, but talk about the publicity that got, and what you knew. You said it a second ago, was that what do patients care most about? Their time. What do doctors care most about? Their time. And so focusing on giving people back their time, something you don't get back. And I think that's one of the most precious things that we oftentimes forget and be a huge motivator to get people to change, improving their quality of time, how they spend their time, what they spend their time doing. And I think if AI can give them back their time, then that's the key to success and getting adoption.
Let me try to end with a program that I did at the last AUA, and the title of the program that I gave was Doctor Getting Home for Dinner. You remember that?
Right.
And the doctor of today is burned out. He is stressed. He is buried in paperwork. And they finish the day at 5 or 6. They come home, and then they've got 2 to 3 hours of signing out the EMR, and they don't have good quality time with their family. I think if we can show that the doctor becomes more efficient and is home for dinner, the AI will hit a home run. As if when the doctor is home for dinner, his quality of life improves, his relationship with his family improves, his own stress level is reduced, and he gains more enjoyment from the practice of medicine when he or she is home for dinner. So I think, that is our challenge, Jeffrey, is that if we can demonstrate AI can make the doctor more efficient, producing less stress, and he or she is home for dinner, we have a game changer.
Right. No, and if you look at that, and I'm not trying to oversimplify it, but the vast majority of anything that gets adopted in a large scale does deliver on that one key element, is it's giving you back time. I mean, that's the whole concept of the microwave, right? What used to take 3 hours to cook can be done in 30 seconds now. The drive-through. So people always embrace things that give you back your time, because that's one thing that you can never get back, as they say, and we're all on borrowed time. When you think about what is most precious to you, doesn't matter how much money you make or how many things you have, and all the stuff you could afford to buy by leveraging AI to make more money, you're never going to get back that time. So I think that's where the rubber hits the road. And I think what we're concluding on, maybe it's a good way to end the topic, is the balance here, to summarize, is that machine learning does not replace a doctor, never will, but it will complement, support, assist, improve capacity, and best of all, let's hope that it gives back time for both the patient and the provider. And I think if it can achieve fundamental goal, then we do have a winning combination to see adoption. And I think we're going to have to work through the ethics and intellectual property and consent, and what happens if a machine makes a mistake. All those things are going to have to work itself through the compliance and the regulatory folks, which no different than EMR will have to go through the vetting and whatnot. But I think if you're not embracing it, then it's going to be a classic scenario where you're going to be technologically isolated from your markets as well as your patients. So I think that's a good note to end on. And Doctor, as always, very insightful. I enjoy our conversations. I know we've had long talks about many different subjects, and I'd say this is definitely one that's going to go down the books as one of my favorite topics to spend time with you on.
Well, thank you for the invitation. I enjoyed this hour together. I look forward to collaborating with you again in the near future. And I think we need to tell the listening audience that we are about to embark on a book together, a revision of the book on managing and controlling a healthcare practice.
We appreciate that. And of course, the article that you were referencing throughout this podcast, Jessica will make that link available for those that want to have that. And I always like to remind people that at no cost, you're more than welcome to reach out to myself or Dr. Baum if you need any insights on a variety of topics. We're always open to having those conversations with you. Feel free to get in touch with either one of us. So thank you.
We hope you enjoyed that episode of Coffee with Coker, and we thank you for listening. We want to encourage all of our listeners to participate and contribute in the podcast. So if you have any questions on any of the things we discussed in this episode, any of the topics that were presented, please feel free to ask us. Also, we welcome your feedback and suggestions. If you have any ideas related to the material we discussed in this episode, or in any episode,
please let us know and we'll make sure to incorporate it. And if you have ideas for topics you'd like to hear more information about in future episodes, please send those suggestions to us. We would love to hear them and we'd love to incorporate them into our future episodes. You can find us online and on social media. Start with our website, and specifically the podcast is coffeewithcoker.com. You can also find that through the main Coker website at cokergroup.com. You can also find us on social media, Twitter at Coker Group, and then on LinkedIn, you can search for Coker Group and find our page and the page for some of our team members as well there. So you can find us and reach out to us a number of places. And then if you want to contact us directly, one of the best ways to do that, email feedback@cokergroup.com. That's feedback@cokergroup.com. And again, we'd love to get your feedback, and we'd love to encourage everyone to subscribe to the podcast so that you can be notified when future episodes are released. We look forward to the next episode, and we look forward to getting your suggestions and feedback on this episode. Thanks for listening, and we look forward to speaking with you again on future episodes.